Afternoon, everyone. This is Caroline Mackenzie. I'm Jane Clapham. I'd like to thank the organisers for inviting us today to speak to you about the development of the guidelines. We're not actually going to talk to you about the content very much of the guidelines. They are available. The copies, paper copies, are available on the Polymem stand. Ruthie very kindly brought 2 boxes with her, and I'm sure she doesn't want to take them home. So Caroline and I work at St Thomas's. This is a picture of a view from our hospital. Sadly, it's not a view from our office. But I feel very humbled today to be standing here, coming from a country where we are very well resourced. We're not as restricted as most countries in the products we use. And so the guidelines actually do reflect the fact that we come from a very well-resourced country. Oh, I have to do this now. Okay. So what we'll cover today, we're going to look at the background of the development, the key recommendations that we came up with. We're going to consider the value of CPGs, how they can be used and by whom. We'll discuss their strengths and their weaknesses and considerations for future developments of CPGs. This presentation will not cover specifics of wound care management because we feel that you are all experts in that, so we don't need to cover that. Some of what we're going to say has actually been covered by Katia, but hopefully a bit of a refresher for you. So, what are the clinical practice guidelines? Well, I wouldn't be able to talk about these guidelines without providing you with a bit of history on the first edition. So I'll come on to that in a moment. But their aim is to provide a framework to reduce the variation in practice, to improve patient care and hopefully quality of life. The first edition was the first of its kind that we're aware of. There was a paper by Pope et al. That was published shortly after the publication of the first edition guidelines. They're not meant to be prescriptive. They are purely a guideline. We recognise that each person with EB is unique and they have different needs. And the emphasis must be still remaining on the clinician to use their own judgment. And we hope that you can adapt them to your own needs with your own local resources. So the history. It started over a glass of wine with Liz Pillay and Jackie Denyer back in 2010. Actually, it was probably more than one glass of wine. They won an Ergo Foundation Education Award to fund the development of the guidelines. And the first edition were completed in 2012. They held a workshop during the first advanced EB course in London in that year, in 2011, I think it was. And they sought the views of international EB experts. But due to their lack of experience and guidance, a systematic literature review was not an integral part of the development, and this is something that they freely acknowledge. A draft copy was sent to patients, practitioners, wound care experts for their input, and their comments were given consideration for the final version. Those comments came back from UK, Spain, Netherlands, Australia, and of course New Zealand. So the second edition, the history, it started in 2015. It took 2 years to complete, and in 2015 is when I became involved in the project. I'd been working with Jackie and Liz prior to that, but I hadn't had any involvement in the first edition. As I say, it took us 2 years to update the guidelines. I could have given birth to an elephant in that time, and it probably would have been less painful. Just a word of warning, I'm sorry, Katia, where is she? That they are very time-consuming and fitting it in around clinical need. We didn't receive any funding to develop these guidelines. And to avoid any bias, we had no knowledge of which wound care companies had sponsored the publication. So they were published by Wounds International. So why were they developed? Well, ultimately, to improve patient care. As Katia mentioned, it was identified as a priority area by the EB community, and it was felt vital to involve patients and carers' experience in their development. As I said previously, we feel that they are the experts in their own care. We needed a tool to help guide practitioners who had limited experience or very limited knowledge on the area. We were constantly getting requests from healthcare professionals, both in the UK and abroad, as to how to care for people with EB when they came in contact. Maybe they knew nothing about EB, they had very little knowledge about how to care for people with EB. Work was being duplicated, we were doing emails and phone calls, and we felt that this was just creating more work. And it was also an idea to reduce the variability of the advice we were giving. We wanted to be consistent in that. So bringing together a pool of experts to capture their knowledge to improve patient care. And also at this point, when the first edition were developed, the Deborah network had not been established at that point. So how were they developed? Well, we reflected on lessons learned from the first edition. The lack of comprehensive literature review, for example, did lead to a certain amount of criticism within the EB community. And so we wanted to redress that. We acknowledged the importance then of the comprehensive systematic literature review, so we undertook some training. You saw a photograph of that earlier, to equip us with the skills. For this review, we used the SIGN system, that's the Scottish Intercollegiate Guideline Network, to develop clinical practice guidelines within the NHS in the UK. Conducted a systematic review between 1980 and 2016. We restricted it to English language and humans. We reviewed 1,342 abstracts, of which 70 were included. We sought feedback from patients and professionals in the UK, Ireland, Denmark, Australia, India, USA, and of course Deborah International. And that feedback was again used to modify the document. I'm going to hand over to Caroline. She's going to do the next part of the presentation.
Thank you, Jane.
There's your pointer.
There's my pointer. Okay, next slide. So these are the key recommendations based on the results of the literature review and the experience of the guideline development group. I won't be discussing each recommendation in detail. As we've said many times, they're available online or at the Polymem stand. So one of the key recommendations that came out was the recognition that EB is a lifelong disorder, and that in the ideal world, you should have specialist input to reduce the complications of EB and to improve quality of life. And that input should ideally be at a specialist centre with a multidisciplinary team of specialists. We're very fortunate in the UK that we do have an MDT team with specialist medical and surgical staff and allied health professionals as part of our MDT. But we view very much that the input of the patient, the family and the carers are vital to this team approach, and so they are an integral part of our team. So one of the other key recommendations was in the care of the newborn, in that the use of a ligature, not a cord clamp, was to be used to prevent trauma to the umbilical area. So, what little gems did we come out from this CPG, and what do we use? So we use these guidelines every day in our practice as we feel it maintains the focus of patient-centred care. We listen to the patients. As Humphrey said before, you're experts in your own skin. You know what works. What suits one patient for wound care will not necessarily suit another, even with the same type of EB. We feel it's vital to consider patient preference and choice and not what the professionals feel is right. We practice partnership working and listen to patients. We talk about new products and existing products, but at the end of the day, it's the patient's choice what they choose to use or not to use. We're just there to guide them. So product availability, we're very fortunate that we have a huge range of products, but not every country has that ability. So hopefully the guidelines give some other products that are available. We acknowledge that not all wounds heal, that wounds are dynamic, and by that we mean that they change in size and shape, and that can be on a daily basis, and that gives huge challenges for people caring with people with EB. And another message that we very often have to give to non-EB healthcare professionals is don't panic when you see somebody with EB and their wounds. Ask the patient, they're the experts. They'll tell you what works and doesn't work. And we find they're so keen. You're also keen to educate people, and that's the message that we like to give to other healthcare professionals. So what is the value of this clinical practice guideline, and how do we use them? What's so great about this is it is readily available to everybody. It's on the internet, it's on Deborah UK site and the Deborah International site. And it's available to everybody for any type of EB, the Joe public and other healthcare professionals. And we share these guidelines with professionals. So recently we had a patient who was admitted to a hospital many hundreds of miles away from our centre to have emergency spinal surgery. So the guidelines were used to back up telephone conversations that we had with both the nurses and the doctors. And it's another way of just reinforcing the care that we give. And teaching is a really large part of the role that we have as nurse specialists in very many varied situations, from senior medical colleagues to allied health professionals to carers. And we use the clinical practice guidelines to help support that teaching. We also use it to help support our funding. We've had many situations where the use of these specific dressings have been challenged by the community care providers, and they've tried to alter patients' dressings or take them away from them. So we use this guideline to help support the evidence that actually the patients need this, and that they shouldn't be asked to change to different dressings. And Humphrey was saying before about, the energy needed if patients are having to be their own advocates. So we find that this practice guideline helps us be better advocates for the patients to help them with their energy. So what are the strengths? If it's going to change. Oops, that's good. So what are the strengths of this particular clinical practice guideline? So it's a starting block. It's a guide, as we've said before. It's not prescriptive. It's about the use of clinical judgment, but it can be used when there's lack of evidence available. Just checking the time. As we've said before, and Katia said, it highlights the need for new research into wound healing and treatment. And the first edition was actually an impetus for clinical practice guidelines in other areas of EB. And it can be used as a consensus for healthcare professionals who are in areas that have limited experience or have limited numbers of patients. And as Katia said, there are plans to translate it into Spanish and Russian. I'm going to hand back to Jane.
Thank you, Caroline. So the weaknesses and limitations of this document. Well, we only have experience of the UK system, and we've already said several times that we are a very well-resourced country. Today we heard about the healthcare provision in Japan, that only in 2008 they had access to funding for dressings and treatment. There's a lack of quality evidence, which we're all very aware of. It's mostly case studies and personal experience. and our literature research was confined to English only, because sadly that's the only language I can read. It's only as good as the day it was published. Products and practice are constantly changing, and practitioners should review the care. We heard today about new smart dressings, and only recently, since the publication of this guideline, we've changed our own practice at the London Centre, and we're using a lot more honey. As new product has become available with a weaker strength honey, it's more acceptable for patients. It's not so painful to use, so we're constantly reviewing our practice. Obtaining feedback, particularly from low-resource countries, was very difficult, and it's led to a gap in the recommendations that we've made, and we do acknowledge that. So, what are our thoughts for the future? The strength of this document is only as good as the range of feedback, and we need to consider how we get feedback from the EB community and beyond, and how do we reach those low-resource countries? How do we produce our evidence? Dede Morel talked today about the complexity and difficulties of trials for tropical treatments. That was difficult to say. We hear how Deborah is working closely with industry to consider new treatments to ensure that the research is of good quality and addresses our needs. We need to be aware, though, of industry bias or industry-driven research. And remember that there is a value in case studies, case series, and expert opinion. And for the future wound care guidelines, this has already been discussed, but these need to come under the umbrella of Deborah International. They will no longer become published by Wounds International. Oh, sorry. Backwards. Yeah, won't go back. Anyway, I was about to say, here we go. Thoughts. This is, as Caroline's mentioned, they're available to download free from Deborah International, and there's many copies on the Polymem stand. I want to thank everyone. I particularly want to thank my colleagues. Liz Pillay and Jackie Denyer get a special mention because they started it all off back in 2010 with that very large glass of wine. Wounds International for producing the document, and the Ergo Foundation, Deborah, and of course our teams. That's a picture of some of our team. We weren't all there on that day. Thank you very much.